So I'm just waiting for my presentation to come up. I work at the Maudsley Hospital in London, where I've been a consultant for a number of years. I've worked all my life for the NHS, which is the National Health Service in the UK, and feel that I'm a great proponent of community care and interventions and programs which involve the whole child, the whole adolescence, and are based in the community, of course. I'm just waiting. I'm also here as the co-chair of the WPA, which is the World Psychiatric Association, the Child and Adolescent Psychiatry section, and I extend my regards from my co-officers who are very pleased that we've been invited here and that WPA has a presence. So I'm still waiting for my presentation. I'm going to try and wave at the back. What I'm going to talk about, I've been asked today to talk about models of early prevention in child and adolescent, the provision of child and adolescent mental health services. So I'm going to focus on the issue of early prevention. And of course, in order to do that, I will also have to say a few words about detection. So do bear with me. We can start straight away. This is the Maudsley Hospital where I work. And I want to start off with a quote: by promoting good mental health and intervening early, particularly in the crucial childhood and teenage years, we can help to prevent mental illness from developing and mitigate its effects when it does. And this is a quote from a document which has been very popular in the UK called No Health Without Mental Health, which was published in 2011 now already, some 5 years ago, but which has been a sort of guiding light for many of us in forming our policies and talking about interventions. So I'm going to try and make the case for child and adolescent mental health and talk a bit about how we develop services. Before I do that, I need to just set the scene. Children and adolescents constitute almost a third, that's about 2.2 billion individuals in the world's population. Now, the interesting thing about this is that almost 90% of young people live in low-income and middle-income countries. And here is another way of, I'm just breaking this figure down a bit more, so you can see that in the Western, highly developed countries, that proportion is much smaller, whereas in the underdeveloped countries and developing countries, we are seeing a much greater, over 50% population of young people between 0 and 19. So, what is it about child mental health? Well, first of all, as we've heard this morning, somewhere between 1 in 4 and 1 in 5 children will have a mental disorder before they reach their 18th birthday. Not only that, and the high risks associated with that, but the burden of disease is huge. And it is surprising to find out that the global burden of disease, even for children as young as under 10, is greatest for mental disorders, greater than for cancer, greater than for some of the other chronic pediatric conditions. And that should alert us. And finally, 75%, as we've been hearing year after year for the last decade, of all mental disorders start before the age of 25. So, what does that say about child mental disorders? Well, it's worrying, of course, because we ought to be better at identifying it and doing something about it. But I would like to say at the outset that this also gives us an opportunity to do something at this crucial period of change. So it's an opportunity. And you know, some people say these days, some researchers, that the fact that these disorders starts so early, in fact, points to a neurodevelopmental nature of all disorders which develop in adulthood. So we should really be looking at what happens, what are the normal developmental trajectories and how they go awry. What happens? One model would be to look at these trajectories, changes in neural architecture, look and correlate that with developmental stages, and then relate that to the context and the environment. And that is exactly, I think, where our future lies in terms of both child psychiatry and adult psychiatry. And it is only by understanding some of those basics of brain development that we will be able then to look and identify which are the protective factors and which are the risk factors. Let me give you an example. I'm going to use the example of schizophrenia disorder. I borrowed this slide from Tom Insel, who's the most recent, most immediate director of the National Institute of Mental Health in the USA. And his point is that we're really, too late, often too late in identifying illness, and we wait till the symptoms arrive. Whereas, in fact, we should be looking earlier and trying to identify the precursors and some of those changes. And he uses the example of schizophrenia as a brain disease. Now, these are Judy Rappaport's cases at the National Institute. As you know, she has been looking at early onset schizophrenia. It's thankfully still very rare, but you will see here on this slide that these pink, red, yellow bits indicate the loss of grey matter. And as you go on, 5 years later, same subjects compared to controls, that loss of grey matter is even more pronounced. And this is probably the stage by which behavioral symptoms emerge as well. And the point I want to illustrate here is that we all know that grey matter, disappears in adolescence anyway. There's all this pruning going on, yes? Loss of grey matter, and you can see here this normal developmental curve. This is what happens in schizophrenia. So even before these developmental symptoms emerge, these symptoms of schizophrenia, behavioral symptoms emerge, we can already start tracking the trajectory of some of these deficits. And basically, the researchers are saying these days, let's intervene, let's detect, let's identify, let's intervene earlier if we can. And we now have the tools to do this. Unfortunately, this is still research, and we can't use it in everyday practice. But I think I just really wanted to make that point. Although we can't depend on some of these wonderful developments in research, we know from our epidemiological studies, from observational studies, from treatment studies, that in fact there are risk factors which produce outcomes, detrimental outcomes in adulthood. And so we know that children who do have mental health difficulties have poorer health, poorer social and lower levels of educational attainment, higher levels of self-harm and suicide. Suicide is now emerging as the top or second top actual cause of mortality in young people. And we're not that good. It's very reassuring to hear this year that the suicide rates in Russia are going down, because this is not happening in the rest of the world. Smoking, drug abuse, higher rates of antisocial offending behavior, poorer outcomes in adulthood. And knowing all this, knowing that these young people with mental disorders grow up to have such poor outcomes, it's even more worrying to see that less than 25 to 30% of children and young people actually access services. They just don't come to us. And these are some UK statistics. The same thing happens in some of the Australian studies. So we used to say when I first started training, 1 in 10 children gets treated. The other 9 are out there. Nobody ever hears about them. So how can we make services more accessible and more efficient are basically the two main things that preoccupy us. And I want to say just very briefly something about the strategic direction. So Grand Challenges in Global Mental Health were an initiative set off by the National Institute of Mental Health and partners in the States, and they involved about 400 researchers, clinicians, advocates, and so on from all over the world, and they basically came up with 4 major themes. And we've heard this morning the number of issues and themes which keep repeating themselves from one policy, you know, WHO, WPA, global challenges of mental health. These are very similar challenges and themes, and this is the same. There should be a life course approach. There should be cooperation, you know, social services, education, health, voluntary agencies must work together. This is not just the health issues. Interventions have to be evidence-based, and context matters. You can't just translate one thing to another from one country to another without piloting it and testing it. So these are some of the more CAMS relevant things which the global challenges for mental health have come up with. So supporting community environments, physical and mental health, again emerges as a team. Poverty, I wish we could eliminate poverty. It's a very noble ambition, but I'm afraid we're far away from some of that. Childhood abuse. There is so much research out there these days which points to early abuse producing detrimental effects in adulthood, not only in the immediate lives of the children and the suffering. So evidence-based practice and so on, and we'll come to these issues in a moment. So how do you form a service? You know, how does one go about? I've been doing this. Even, you know, when I first started working, we're a tiny team in a huge borough, you know, 300,000 children. There were about 5 or 6 of us doing the whole job. So how do you go about this? You know, I think you have to realize that you can't just go on doing clinical work all the time. You have to become a bit of a manager and a politician as well. So, you know, one needs to start off with a needs assessment. You can't set up a service without knowing what is out there. And that is extremely important. You need to involve stakeholders from the beginning. You know, like you had your minister here this morning, you had other ministers from other agencies. This has to be a joint effort. Don't go alone. You know, start from the beginning involving people. We've got to start using evidence-based treatments. You know, we have for many years as psychiatrists used treatments which we like. I mean, like has nothing got to do with it. You know, we actually need to say, all right, there's been a randomized controlled trial here. This makes sense. I will try this treatment. And you need to explain to your patients what's going on. Finally, you know, staffing is a huge issue. Things have to be piloted before there's a huge national investment. You know, you can't ask for your millions until you've actually piloted something on a smaller scale. So you need to be, you know, aware of the risk factors. You need to, so you've got in blue there the risk factors, and in green the protective factors. So it's about knowing these, and I'm sure you're well familiar with all these aspects of what causes difficulties for young people. Starting with biological factors, psychosocial issues, school and community issues, family factors, and so on. And it's working on those protective factors which is going to give us the best prevention programs. So how do we involve stakeholders? Well, you see, we have, I don't know if you can see here, but those are graphs showing investment into mental health in the UK since 2006, 2007. And at the moment, we have data for 2012, 2013. The thin line at the bottom is CAMS, is child and adolescent mental health services. Only 6% of all adult mental health investment goes to children. tiny amount. So we need to start saying we need more money, and in fact we've succeeded, we hope, in the UK. We just have to see what this new government does now and whether they honour the word of previous policymakers. Because if we don't, and again, it's important to have this information to hand, if you don't, you are then incurring costs later on in life. Just 1 year in foster care costs the local government around £35,000, and probably more, because these are slightly older figures from about 2012. So just admitting a child to an inpatient unit costs somewhere around £24,000 a year. So these are huge expenses, and we can actually say to our stakeholders and our commissioners, look, if you don't invest a bit of money in prevention and treatment, this is what it's going to cost you later on. So that's just highlighting how important it is to make the economic case as well and to collect the data. We have good treatment programs at the moment. We have become much better at evidencing our practice. We have good parent and teacher training. We have good child abuse programs, mental health promotion in schools, early intervention for psychosis. So let's use those programs. We don't have to reinvent them. They're out there. Unfortunately, in evaluation of some of these treatment modalities, we see a situation, as Chris Keeling from Brazil and colleagues have pointed out, where looking at the world population and practice, although most of the children live in these low-income countries, you see the end graph there is people younger than 18 years in low and middle-income countries. And next to that graph, you have, it's working, people younger than 18 years, the trials, tiny amount of trials, randomized controlled trials, where you have an opposite situation in the West and in higher income countries where you have this huge amount of research on a much smaller population. So we need to rectify this across the world. Now, I go back to that slide about how you set up services. You need trained staff, and no country in the world has enough trained staff. But these are the recommendations that were given by the Royal College of Psychiatrists and a particular working party on building capacity and skills for child and adolescent mental health services. And put your hand up if you have this is per 100,000 population. Do you have almost 20 people in your team per 100,000 in some places? We certainly don't. And in teaching hospitals, that thing goes up to 24. And we're talking here about skilled mental health workers only. So these are actually serious numbers, and we're going to have problems with workforce recruitment if we follow some of these guidelines. Back to how you run a service, what is terribly important is that you work, not only on a multi-agency level, as I set out in the beginning, but that you work within the organization, with your academic colleagues, with your management, and, as a clinician, obviously you're running your clinical services. So at the Maudsley, we have a tripartite, we have a sort of a triumvirate of management always, where we have 3 clinical directors. And the 3 clinical directors run the show, all right? And they have to get on well, and they have to deliver, but it means, we deliver within budget, we make sure we get our marketing and business sorted out, we make sure it's evidence-based and the outcomes are good, and we make sure that that translational research gap, which is so prevalent everywhere, is shortened, yes? So that if some good research comes out, we can pick it up and run with it without waiting for 20 years. When did we know smoking was bad? In the 50s, yeah? It took us 40 years to get there. And I think a lot of that happens in a lot of medicine. So I come to some examples of service models, and this is a document called Future in Mind, which is very comprehensive, which is online on the internet, which is the latest document on how to commission and run mental health services for children in the UK. The themes are the same, but what the document very much depends on is this tiered. You saw Professor Saxena's pyramid this morning, but it's extremely important to have this community primary care baseline where it's everybody's business to look after children's mental health and well-being. So, teachers, social workers, GPs, and so on. And then as you go up the pyramid, the services become more specialized. But one of the criticisms, we've had this for years, but one of the criticisms addressed at our services was that we are too protective of our various tiers, and if you get in at the bottom, you really have to fight your way to get into an inpatient bed or into a specialist service. So we want to make this transition through the services much easier, so we might want to make it possible for children when they come into the service to get the right kind of service. Because as we always say, children don't read our policies and our textbooks and our plans. They just come, with the difficulties, and families just want the right sort of help. And I'm going to finish by alerting you to another amazing primary prevention model. And I don't know if you've come across this, but this is the Australian Headspace program. It was set back in 2006. The Australian government, in the first run of the program, invested something like 60 million in developing these walk-in centers where young people could walk in and get help for anything ranging from minor school problems, relationship difficulties, minor issues with health, sexual health, to more serious mental health issues. And the program's been so successful that it's now reached somewhere around 60 centers, and it takes place in rural and urban centers. It's well frequented. Something like 50,000 young people attended these centers, which are in shopping malls, in high streets. You just walk in and talk to a counselor. They have online services now. I just, again, wanted to alert you to this excellent example of primary, or I suppose secondary intervention, but also to say, the Australians are investing more money into this. And if you recall, they were the first ones to talk about early intervention and psychosis as well, if you remember, the IPP, Prevention and Intervention Centres. But what the authors of this program say are that this sort of service must inevitably be supported by a more specialized